Okay, listen, I'm very happy that I can briefly talk to you about this subject matter, i.e. pregnancy in the Crigler-Najjar syndrome, because, this has positively changed since we first met. 25 years ago, the idea that a woman with the Crigler-Najjar syndrome could become a mother was something we didn't really believe in as a tangible possibility. Now, we have here Beatrice, Valentina, and other women who have become mothers, which is the dream of all women, I believe. And this gives us joy and certainty, despite the many concerns and fears and problems we have lived with respect to the destiny of the patients. Having said that, we had concerns and doubts about the possibility that these women could become mothers because we were afraid that the bilirubin levels could cause damage to the fetus during pregnancy. The data shown in these slides arises mostly from a paper presented in Bertinor in 2006 by our Dutch colleagues, and the data refers to what the medical literature told up until then. These are the published reports they examined, 6 in all, and the case reports in the literature concerned 6 Crigler-Najjar patients with a total of 8 pregnancies up to 2006. Those were the published ones, and then, as you know, in medicine, when something is not so rare and strange, well, it's no longer very interesting for journals. And so at a certain point in time, the publication of the next following pregnancies had no reason to be published. So probably we have many more than these. We can say many more things in the light of facts that have occurred in the meantime, i.e. of the other women who've become mothers and of the children who've been born. But back then the situation was this one. 5 patients with Crigler-Najjar type 2 syndrome. 1 had taken phenobarbital for the whole pregnancy. 2 had done phototherapy followed by phenobarbital. 2 had done phototherapy. And all of these children had been born healthy. There was a case report of a patient with type 1 Crigler-Najjar syndrome, and during pregnancy her bilirubin levels were fairly high. I've translated them in milligrams, about 21 to 27 milligrams. This pregnancy ended in a cesarean section, probably for some complications occurred during labor. And the bilirubin value on the umbilical cord was very high, 23 milligrams. In the first period of life of the child, there appeared to be no neurological abnormalities, but then there was spasticity. And this was caused by the bilirubin levels. And these symptoms have stayed over time. But first thing first, this mother who has had these values of bilirubin throughout pregnancy hasn't had the possibility to keep bilirubin lower. We don't know why. We don't know if she chose to do so or for other reasons. But for sure, with a standard phototherapy, probably she would have had lower values. We have to consider this situation as a non-usual situation with respect to the correct management of the syndrome. And the fundamental doubts were what level of indirect bilirubin can be considered to be safe for the fetus during pregnancy. And then again, is it possible to continue phenobarbital therapy during pregnancy because of the potential toxicity of phenobarbital? And I'll talk about that. And another doubt related to the fact that the derivatives of phototherapy, photoisomers, can not be safe for the fetus. With respect to this, we found that photoisomers don't really cross the placenta, so they don't have an impact. In any case, the photoisomers were present in all children who had received phenobarbital in a very low amount. The speaker corrects himself, who had done phototherapy in the pregnancy. There was a very low amount in the umbilical cord, and there was no substantial damage. Instead, this chart relates to an animal study and explains a very simple fact, i.e. that the UGT1A1 has an activity which, during pregnancy, the animal didn't have up until the end of pregnancy, i.e. 22 days, and then it progressively increases and the maximum effectiveness is reached during adulthood. This also happens in newborns. They have physiological jaundice because the action of enzymes improves in a matter of few days. Going back to the problem of safe levels of bilirubin, now then, should we start from the data in the literature existing then? What is the problem? Well, the problem is that no one doses bilirubin in the fetus. I mean, back then, they didn't do it. Now it is possible to infer this from the possibility of doing micro blood workout in the uterus on the fetus, but there's no substantial documentation of this notion that can be applied as such. I mean, we can't say that there is a cutoff value. There was back then evidence that the lowest value of bilirubin associated to the appearance of nuclear jaundice in a newborn was 200 micromoles, i.e. 14 milligrams. This is very high in the first day of life of a newborn, and all of the guidelines for phototherapy in the newborn say that phototherapy should start at 6 to 8 milligrams. So a child born with this value would be immediately subjected to phototherapy, including probably plasmapheresis. So we could say that since at lower levels there had never been nuclear jaundice in a newborn, a barrier of around 12 milligrams should be considered as being a safe value. However, another rare case was a baby with 18.8 milligrams at birth, immediately treated with phototherapy and exsanguinate transfusion, and then had no problem. So high value, treated in an emergency at birth, and they avoided the stabilization of neurologic damage. As I wrote on this slide, the general clinical conditions of the newborn are a very important variable, quite apart from the absolute value of bilirubin. Because the fact that there can be an infection going on, or that the baby is premature, or that he had asphyxia during labor, immediately changes the risk of neurologic damage caused by bilirubin. So with much lower levels of indirect bilirubin, that newborn would run risks because he's already had asphyxia and has an ongoing infection and so on and so forth. As regards the possible problems of phenobarbital during pregnancy, the medical literature, taken as a whole, shows an increased risk of abnormalities, 6.5% versus 1.6%, which is the total number of women who don't take phenobarbital, have a bias because they refer to patients who use phenobarbital alongside other drugs and for epilepsy and at high doses, because of 150 milligrams or 1.5 grams per day of phenobarbital is, how can I say, a very high dose. And in any case, it is necessary to control some forms of epilepsy. What we know, based upon experimental data, is that phenobarbital would induce an apoptosis, which is a special cell damage that occurs in the neurons, i.e. in the nerve system cells. And this risk is most high in the first trimester. And there are no studies on the combination of jaundice and therapy with the phenobarbital. I mean, this could increase the risk of damage if you have jaundice and take phenobarbital. Instead, the children born from CN2 mothers taking phenobarbital up to 60 milligrams per day, we have 3 cases in the literature. All of them are healthy. We should also consider the potential risks for a woman with this syndrome during pregnancy. Well, in the first trimester, there frequently is vomiting, which causes the loss of liquids. And since this means that the blood is more concentrated, because if you lose liquids, there is less liquid in the blood, and so there is an indirect percentage increase in bilirubin. And that's a risk for the mother, a potential risk for the mother. Towards the end of pregnancy, instead, there's a frequent reduction in the level of plasma albumin and of the capability for it to bind with bilirubin. And bear in mind that this mother has to protect herself from her high bilirubin. And so this unbalance in the albumin-bilirubin ratio is another potential risk. And then, during delivery, if a woman was having phototherapy during labor and delivery, well, this becomes secondary. I mean, phototherapy can be suspended, and the delivery can be cause of bleeding. And this means more production of bilirubin. Likewise, you can have destruction of blood and tissues. If there are other substances and pigments and enzymes, as Lorenzo said, they are potential precursors of bilirubin. And as we said, during labor and delivery, phototherapy can be interrupted. These are the potential risks for the mother. So, our Dutch colleagues have made the Rotterdam recommendations, which were prepared by the Rotterdam Working Group. First of all, it is fundamental, prior to decide to have a pregnancy, to have a genetic consulting. And this not just for CN future moms, but also males. They shouldn't fall in love with a person with the syndrome, and they should also verify that the person they're in love with is not a healthy carrier. Because if I'm a diseased male and my partner is a healthy carrier, well, we can have a diseased child. So genetic consulting is not only for the women with the syndrome wanting to have this pregnancy, but also males wanting to become fathers. And then it is important to discuss the potential problems, the ones that I've already talked about. because you should be informed of the fact that in any case that pregnancy will be managed by gynecologists as part of the program for pregnancies at risk. And then taking folic acid is not strongly related to the Crigler-Najjar syndrome per se. And over the last decade, a simple, powerful tool has been created to reduce the risks of the neural tube during pregnancy, which lead to defects of the nerve system. Even more so in a pregnancy where there is the potential risk of toxicity coming from bilirubin, we have to minimize all of the other risks to the extent possible. And taking folic acid should start several months before pregnancy, because we need a loading phase to concentrate the folic acid in the body so that it can correctly protect the body. And this should continue throughout the pregnancy. And then it goes without saying that we have to have regular measurements of bilirubin and albumin, and phototherapy should be adjusted. I mean longer hours or increase the body surface irradiated, or both, so that bilirubin can be kept as low as possible. That's the idea behind that. I continue to talk about the level of serum bilirubin to be kept, i.e. 12 milligrams. That's important, even though the bilirubin levels have gone up to 14 and 15 in the pregnancies following after these recommendations, and nothing happened. I mean, it was all right. And then if you're in the hospital, well, everything will be done for the mom and the baby. I mean, here we talk about the mom and the newborn, but we know very well that the hospitals that could ensure phototherapy to moms are zero. If you want it, you have to take it from your home, not just in Italy, but also in the other countries. And then you should avoid drugs increasing the levels of indirect bilirubin. This is something we are aware of. And finally, there should be a neurological follow-up of the children to verify over time if and which symptoms occur, which could be related to neurologic damage caused by bilirubin during pregnancy. This is the story of two case reports described by them. She was 27 years old during the first pregnancy. At 9 weeks of gestation, her serum bilirubin was 235, 13.6 milligrams, and albumin was 43. So the ratio bilirubin-albumin is optimal. But since bilirubin was high, they increased by 3 hours per day phototherapy, and bilirubin was lowered, about 2 milligrams left. This is the difference between 234 and 205. Albumin, in the meantime, had gone down to 34 grams over the last trimester of pregnancy. And since there was a mild proteinuria, delivery was induced at 39 weeks without waiting any further. At birth, her bilirubin was 239 milligrams, so more or less the value she had at 9 weeks of pregnancy. The boy was healthy. The APGAR score was 8, which is the general index of reactivity at birth, and it was very good. And the level of bilirubin in the cord blood was the same as his mother's. Then it went up temporarily to 278, and albumin dropped to 30 grams per liter. The boy was treated with phototherapy for 3 days, and everything was okay. Second pregnancy of the same mom, 2 years later, bilirubin and albumin levels were similar to the first pregnancy. She gave birth to a healthy girl at 39 weeks. No problems, and both children have developed normally without hyperbilirubinemia or neurological abnormalities. So, in conclusion, we can say that it is reasonably possible to have a safe pregnancy in CN2 and CN1 patients if the levels of bilirubin are kept possibly under 14 milligrams before and during pregnancy. If phototherapy is a benefit in the first trimester, this means that you can discontinue taking phenobarbital in the first trimester because it is the period of highest risk of damage caused to the nervous system by phenobarbital, the nervous system of the newborn. It is important to have genetic counseling with a multidisciplinary team. And finally, it is important to deliver in a hospital that can ensure phototherapy and can also provide plasmapheresis and EXT to promptly step in the event of bilirubin levels being worrisome. With that, I'm done, and I thank you for your attention. Any questions? Any pregnancies? Beatrice, would you like to say something? I didn't invent anything. And after the case reports in the literature, I mean, at the end of the day, I have lived your experience, and I was so, I had a lot of peace of mind. And I knew that the maximum tolerable level of bilirubin was okay and lower than the levels shown in my presentation. Okay, first of all, we would like to give a gift. Flavio, you have two persons giving the gift to you. Yes, that's because Olivia and me are falling in love. Olivia is the little blonde baby. Sorry, I've made a mistake. I'm her pediatrician. She would never bring flowers to me, so it was Anita. Thank you, Anita. A question and a curiosity. Quite apart from the neurological damage that you explained so well, with respect to the bilirubin levels, can there be slight contraindications in a pregnancy with those levels of bilirubin? Slight, what do you mean? Below those values and having slight problems? Yes, like itching. Okay, fair enough, but that's a question for the gynecologist. No, but I mean, let's say that most cases of itching are related to biliary salts, and they're not directly related to the levels of bilirubin, so probably there's no direct relationship between the two. If I have jaundice, I can't say that I will have more itching than another woman. There's no direct correlation. We can state this. I, as a pediatrician, can state this. I just wanted to say that, I mean, this is my feeling that I would like to share with all of you. This is something we've gone through directly. So, according to me, Crigler-Najjar moms, quite obviously, decide to become mothers. They're fully aware. They and their partners or husbands are fully aware of wanting to become mothers. And pregnancy in a CN mother, according to me, is lived in a very special manner by parents. You know it very well. You know the state of mind is different. I mean, despite the fact that now, I mean, we have peace of mind. I'm talking about Beatrice. When she told us she was pregnant, you know very well what we thought. It should have been the most beautiful piece of news in the world. I mean, it was, luckily. But we were not prepared. We were surprised. For sure, Samuele, her son, her second son, has been a different experience for us as well. I just want to say that you helped us so much also during that moment, and you know it. So I wanted to say so to the whole world. Because these are special moments. And then, as you said, now, I mean, we've seen that we can have beautiful, healthy boys and girls. So that's quite an achievement. Okay, thank you, Cristina. But quite obviously, I think that what we all agree on is the fact that when people have to tackle difficulties and periods of suffering because they have situations that, cause difficulties, I mean, everything becomes more difficult. But then, when you're successful, you're so joyful. You can't even measure that joy. You can't say, I love my boy or girl even more, but you would say so. So, that's an experience that affects most especially patients with rare diseases because they have huge difficulties to have something that is so natural for others in their daily life. So, okay, it's time for tears, like in TV shows. And I think that it's a nice moment. When we have these annual meetings, this moment is so important because aside from the scientific information and knowledge and teaching, and aside from asking the experts to find solutions and tell us where we are, we encourage each other by sharing experiences, including positive stories. Otherwise, these annual meetings wouldn't be so pleasant. I'd like to thank you. Going back a decade ago, this is my personal experience that I would like to share with you. In 2006 in Bertinoro, the clinicians, most especially Ms. Brun, showed to us these slides on pregnancy and commented on them, saying that a Crigler-Najjar woman had to forget about it and not become a mother. And I was so sad when I heard her say so, because that was one of my biggest expectations. So I want to share this joy of mine with you today, because a decade later, I've become a mother. That's my dream. And I think that this is important also for the other girls who will become moms as well. It's important for them to see that it's doable. But I wanted to highlight that it is very important to be aware of the fact that in any case, it is a hurdle, an obstacle. So, it is important to be aware of this event since the beginning and be aware of the fact that phototherapy needs to be done and even more than usual, and that the drugs are to be taken even more than usual, and that quite obviously this approach must be a steady one, a seamless one from the time you plan your pregnancy to the time the baby is born. So thank you very much again, because as usual, you've been so hugely useful to me. Yes, but we also have to say that Professor Labrun gave you advice during pregnancy and helped you a lot. And maybe he may have thought, I shouldn't have said that. Okay, you can now conclude the meeting. Okay. I would like to say the following. We are taking further steps ahead with respect to the gene therapy project. Many of you know that up until 4 to 5 years ago, I was one of those who were so skeptical about the arrival of gene therapy. But I changed my mind, and I did so when the gene therapy was done for hemophilia type B. And now I'm convinced that the efforts being made by the group are the right ones in order to hit this goal. It may be a partial or full result. It may come in 1 year or 2 years' time. I mean, we'll see with time. So I believe that today I feel much better. And this leads me to answer to the question we've received from the web about what choice needs to be made. Well, I very much hope that when the gene therapy is available, you can simply say, I have one more option. I can make a choice. I'm not obliged to choose just one option. And I also think that luckily, if it's not going to be a solution for all, in any case for the others, there will be a solution. There already is a solution, i.e., it's not a single action, but it's something that is available to the people who decide one day to have a liver transplantation. The little ones can wait and really see the evolution of the project, the gene therapy project, in reasonable safety, providing that phototherapy is correctly done. They don't just have to wait and do nothing, quite obviously. So at the end of the day, from last year to today, we've taken some steps ahead. And this, per se, should make us feel better. We must be aware of the fact that we have our merits. We as an association, quite obviously, all of us have a merit because we have worked to take this path. Because, for example, the fact that now we have a follow-up to identify the carriers of antibodies against the adeno-associated virus, and we have as many as 19 persons in Italy, we've done a good job. I'm sorry, Marlene. I meant that in percentage terms, we've been better, because we also have many French. So this means that there is a good level of awareness. I mean, you and I are aware of the choices that are being made. You always thank me, but now I have to thank you. It's not a given that you have to trust me and what I say. It's not a given that we have to trust what Federico Mingozzi says, but it is reasonable to trust the things which are correctly documented. We've always shunned therapeutic options which are not evidenced. We've always tested things. This is what we are doing, and I believe that this is the only right path we have to take in our best interests, and that's all.